Today's presentation is about retinopathy of prematurity. What can we do to change the outcome? The ROP is of primordial importance in management of babies in the neonatal ICU because if you simply don't treat them, they get blind. So the ROP is a pathological process of the premature with abnormal retinal vasculogenesis, and it might progress to proliferative vitreoretinopathy ending in blindness. Of course, it's related to retinal development. So the more premature the baby, than 8 months of pregnancy, the more the retina is less developed and the vasculature is premature. So of course the temporal retina vascularization goes to the periphery at a later stage than the nasal retina, and the development is mature by the end of the 8th month of pregnancy. This is why any child with premature delivery has the potential of harboring a stage in the retinopathy of prematurity. The development of the retina in utero depends on the oxygenation, and the normal intrauterine vessel growth usually starts by week 20 of the post-menstrual age. The more premature child has a stage 0 ROP, where the vessels simply stop at the retinal periphery and they don't go to the very far periphery. If this goes into a line, a demarcation line, we're talking about stage 1 ROP. If the line gets elevated on top of the retina, on top of the internal limiting membrane, and projects into the retina, we're getting a ridge of stage 2 ROP. If the ridge acquires new vessels, vascularization, so we're talking about fibrovascular proliferation of stage 3 ROP. Usually when the stage 3 ROP gets a plus disease, denoting vascular incompetence with dilatation of the vessel, we're talking a type 1 ROP, and we will be discussing the staging further. This stage needs immediate treatment with cryotherapy or with laser therapy or with anti-VEGF, depending on the degree and the extent, and we will go through the different changes and the different management techniques. So simply, why is ROP of importance? Because Egypt, we have the live birth, according to the 2014 census, is between 20 to 29 per thousand live birth. And ROP is emerging as a very important cause of blindness because the care of children in the neonatal ICU in Egypt is tremendous, and they do survive. We have the 600 grams now and the 700 grams. Our fellows of the neonatologists, they do a great job in keeping their life. And of course, they do cooperate with us in keeping them safe and sound and seeing as well. In the countries where the live infant mortality rate is less than 10 in 1,000 live birth, the ROP is the second most common cause of childhood blindness. Like the United States and Europe, it represents 60-20% of the childhood blindness. So we should know that 19% of pediatric blindness around the world is due to 90% of pediatric blindness around the world is due to ROP. It's present in 66% of infants less than 1,250 grams at birth or less. In 82% of infants less than 1,000 gram at birth or less. And we're expecting a third epidemic in countries like ours. We have to prevent ROP because the longevity and the life expectancy of such children is around, in Egypt, the median age is at around 70 years of age. So we have to do all efforts to prevent blindness. So what's the preterm birth definitions? Live birth before 37 weeks is completed is considered preterm. Late preterm is between 34 and 36 weeks. Moderate preterm is 32 to 36 weeks. And less than 32 weeks is the very preterm child. And this is our target in screening the children. The target population is the birth weight less than 1,500 grams and the gestational age less than 32 weeks and with comorbidity and receiving oxygen. if the child is a little bit more and having sepsis or unstable conditions, it is considered as a target population to be seen in the ward, in the neonatal ICU ward. The American Pediatric Association, American Academy of Pediatrics, and the American Academy of Ophthalmology have revised the children to be seen even when they are beyond 1500 grams and up to 2000 grams and more than 32 weeks with an unstable clinical course at the discretion of the neonatologist. So if we go to a neonatal ICU and we find the neonatologist asking us to examine more of an age and more mature babies, because he saw that these have a very unstable course, they had sepsis, they had to be ventilated, they had oxygen delivered to them to keep their surviving. We have to examine those kids as well. The ROP project has to be a coordinated effort between the ophthalmologists, the pediatricians, the family, nursing staff, the social worker, and of course the administration. And we all have interest in keeping the children sound and safe and seeing. We'll all be very pleased and very happy to keep them seeing. So it's a matter of primary prevention. This is a core in primary preventive medicine, to have the child examined after delivery, a month, 4 weeks after delivery, and it should be well documented, and the ophthalmologist should be notified by the personnel in the neonatal ICU. The matter who will go and do the screening, and does he have to have a level of expertise? Of course, yes. Do we have to use technology? Maybe. Sometimes we have to, and also the logistics of treatment. How are we going to treat the child once the decision is made from the neonatal ICU to the OR and get him back? These are so many logistics that have to be really taken care of. The supporting staff has to keep a good registry, the documentation of the patient, family contact and family notification, and also following up the results. First of all, we have to dilate the children. Of course, using a very minute concentration of cyclopentolate, 2.1%. The usual cyclopentolate is 1%. Kids at that age are not tolerant to 1%, so we diluted 10 times using 0.1% of cyclopentolate and the phenylephrine at 2.5%. We use the Japanese way, 1 to 2 drops to be put once, and we go 90 minutes after the installation of the drops, taking care of the severe complications that can be associated with the medication, with the Mydriatics, or with our examination. So the first of it is the oculocardiac reflex. This is really bad, and we code blue. The kids, the examination has to be in the presence of a pediatric nurse or a pediatric doctor, because the oculocardiac reflex can trigger severe bradycardia and even death. Cornea clouding can happen from severe compression of the globe, transient cataract, postpartum intraretinal hemorrhage, poor visualization due to persistent tunica vasculosa lentis, and the cyclopentolate 1% might induce vomitus or EBS. How do we do the screening? We need to have some expertise in examining the retinal periphery. It's not an issue of central disease. It's a peripheral disease. So we definitely have to put a baby speculum, and we have to have the skills of examining the retinal periphery with indentation. We should use the 28 diopter lens or the 30 diopter lens with the indirect ophthalmoscope, and we use a Q-tip after removal some of the cotton at the tip, and we should indent the retina to be able to look at the periphery, and this is a condition of the examination. We cannot examine the child by simply opening his eyes and looking at the center. This is totally insufficient to report. It's not only that, we have also to document and to draw where exactly the disease is to be able to follow up the patient depending on the staging of the disease. Of course, using the RedCam and the wide angle screening is of importance, because it facilitates the interpretation of the picture, and this is a very important scope of artificial intelligence. Artificial intelligence is going into this right now, and they could read the fundus imaging with the wide-angle fundus imaging using the real-time pediatric retinal camera. When do we do the screening? Well, it's simple. If the child is 27 weeks or more, we start the initial examination at the chronological age of 4 weeks. Yani 1 month after the childbirth, starting from 27 weeks, is very good and enough to start the initial examination. If he is younger, we augment gradually the timing of initial examination. ROP is still classified according to stage, zone, and plus disease. The staging of the disease or the zoning of the disease will depend on a virtual circle of 6 millimeter diameter based on the optic nerve. If the circle contains the blood vessels, it's within zone 1. Zone 1 means that the retinal periphery is very ischemic and the disease can be extremely aggressive. If we go to the nasal retina and the temporal equator, we are in zone 2, and then the crescent that is left is zone 3. طبعا the more the zone, the less severe the disease is. We divide the ROP into stages. As I mentioned before, the demarcation line is the line demarcating the vascular retina from the avascular retina into a stage 1. If the line goes into a ridge, an elevated ridge, we're talking about demarcation ridge, stage 2. If the ridge acquire new vessels, fibrovascular proliferation, it's stage 3. And we denote the extent in the zones into clock hours, and the plus disease means dilatation, tortuosity of the posterior retinal vessels, vitreous hemorrhage, inability to dilate the pupil. All this indicate a plus disease, a more grave disease. This is a demarcation line. This is the line is elevated with demarcation ridge, vascular retina and avascular retina. Again, demarcation ridge, vascular retina and avascular retina, and we can notice the vessels are outgrowing to the avascular retina. Stage 3 here denotes a ridge with fibrovascular proliferation, a ridge with fibrovascular proliferation. Additionally, there is a bad plus disease. Stage 4, the retina is detached, the macula is not in place. 4A, the macula is on, it's not detached. 4B, the macula here, stage 4A, the macula is ectopic. Now, the fovea is very ectopic. This child doesn't have a central vision because of the dragging of the macula by the peripheral fibrovascular proliferation. This is 5A. And 5B, when the retina is dragged and detached, the macula is off into stage 5B. This is such another example of stage 5B, where the peripheral traction induced the retinal fold, and we here have to interfere to relieve this traction. Of course, stage 5 is a blinding condition where the retina is totally detached, and we can see the retina entangled into the fibrous vitreous that becomes fibrosed with traction anteroposterior and the traction that is equatorial, closing the retinal leaves into a very firm retinal fold. Of course, stage 5 is a bilateral blinding condition as in such a child. As you mentioned, the zoning is zone 1, which is centered actually around the disc and not the macula. It's the twice the distance from this to the macula. The circle is means that the vessels are within zone 1 with a very aggressive and bad disease. So it's 6 millimeter zone centered around the disc, not the macula, and this where the vessels lie, indicating a severely ischemic retina and a very rapidly progressive disease. This is a 2 disc diameter, 2 more disc diameter. The fibrovascular proliferation lies within the zone 1, indicating an aggressive condition as such. Zone 2 goes beyond a little bit. Posterior zone 2 is if it's within 1 to 2 disc diameter from zone 1, and we behave like zone 1 disease. This is zone 1 disease. Again, you can see the shunt vessels here as an indication of maybe improvement of the retinal avascularity and the bad disease. Plus disease, as I mentioned, enlargement and tortuosity of the posterior arterioles and venules, vitreous hemorrhage, preretinal hemorrhage, inability to dilate the pupil. All this indicates an aggressive form of disease that might prompt treatment. In the old classification of ROP, if we have 5 contiguous or 8 cumulative clock hours with stage 3 plus disease in zone 1 or 2, this might indicate prompt treatment. As the likelihood of progressing to total retinal detachment if we leave it is more than 50%. What did we do before? And we're still doing sometimes now. We did laser ablation to the peripheral ischemic retina using the small lens, 28 diopter lens, using a speculum, using general anesthesia, and we really have to ablate the retinal periphery into a confluent manner with half disc diameter laser burn, or sometimes less than half disc diameter laser burn, and this is how the retina is ablated, and we in favor of preservation of this posterior pole. If we go for the laser treatment, we have to really to burn and ablate the retina. So the laser treatment aims at burning the retinal periphery and creating a chorioretinal scar. And this is how we used to treat the zone 1 disease here, with confluent burns because of the progression and aggressiveness. And this is a very long-term follow-up. Patient is on the myopic side, but she can see. She still can see in order of 0.6, 0.7 up to 1 with glasses. And this is how we could preserve and save many eyes with the laser in severe diseases of ROP. However, one of the advantages of using technology, the RetCam, is that after we treat, we can definitely follow up the skip treatment of the retina, where we could not apply laser because of the logistics of the small eye, and the indentation is not always in favor. Whenever we skip a space of the retina, we really have to go back and retreat it, because it is an area where we can reproliferate and activate the disease after treatment. So this was the old classification depending on staging, zoning, and plus disease, and the threshold disease that prompted us treatment. A big issue was the posterior disease. The posterior disease was not clearly defined and classified. This is why the early treatment ROP trial have looked back into the classification, looking back at zone 1 disease. Zone 1 progression, despite every treatment, was in the range of 60 to 70% into detachment. So this is why we shouldn't be waiting in zone 1 disease. So if we detect a child having blood vessels in zone 1 disease at any stage with dilated vessels, it is a type 1 that needs immediate treatment. So the posterior disease with dilatation and without tortuosity, or dilatation and tortuosity, or mild hemorrhage, prompts treatment. Zone 1 in presence of new vessels, fibrovascular proliferation in stage 3 with no plus disease, is an indication for treatment. If you go to zone 2, stage 2 or stage 3 with plus disease, is another indication of prompt treatment. Wait and watch policy, anything otherwise, and they should be considered for treatment if they progress to type 1. For simplicity, this table defines the treatment type 1 if we have a zone 1, stage 1, stage 2, and plus disease. Zone 1, stage 3. Zone 1, zone 2, stage 2 plus or stage 3 are indication of prompt treatment. It's very lucky that the prognosis of the ROP is mainly they do regress spontaneously on their own in the majority, in a significant number of cases, and we still look for those patients who would progress and be blind, because the progression here is not forgiving. But we have to really to identify, should we treat or not treat, by many criteria. Of course, the imaging helps, the documentation and drawing help. This child was going to be treated, but I noticed that the ridge here, the vessels grew outside into the retinal periphery, here, and the ridge is becoming piecemeal. It's not a continuous ridge. So the decision here was wait for spontaneous regression, which really happened on follow-up without any treatment. Remember, treatment can be really hazardous and catastrophic. So if, despite you see the vessels growing, the plus disease, but the vessels have crossed already into the ischemic retina, that warranted follow-up with mild reduction in the plus disease, as you can see, and then progression to a normal spontaneous regression without intervention. Remember also that the premature eyes of the babies are vulnerable to long-term complications. Myopia, we have to re-examine them at age of 8 months as we fit them with glasses. Amblyopia, one eye can be more amblyopic than the other because of the retinal fold, because of the dragging, because of the RPE changes that happen within the macula, strabismus, equatorial vessels, and progression, of course, to stage 4 and 5. This child presented as a young adult at age of 16, and once we see the fundus with the temporal or nasal dragging here, and the fovea is totally dragged outside the normal position, and the child has strabismus, RPE changes, or laser marks, we immediately identify that this child was a premature, and we asked the mother and said, yes, he was. In the periphery, changes are of incomplete vascularization, such as these changes, or abnormal straightening of the vessels, vascular loops and vascular arcades, pigmentation, equatorial folds, that's like degeneration, retinal breaks inducing a regmatogenous component, and any form of tractional or regmatogenous or even exudative detachments. So now we know the stage of the disease. What shall we do? We need immediate treatment. Once we diagnose, within 24-48 hours, treatment has to be initiated, and this definitely needs coordination, needs consenting the family, the parents, needs transportation, needs special arrangement for those babies that are really sick. We can move to the neonatal ICU in severe conditions when the child conditions are not allowing with the proper instrumentation and strict aseptic technique that would allow a safe intervention. Portable diode, and we need a pediatric anesthesiologist, of course, with the neonatologist. Paradigm shift has been in management in the last 10 years of ROP management due to the introduction of anti-VEGF into the eye of kids. This was carried out by a Mexican and a Portuguese group in the same time, and we found out that the Avastin, the bevacizumab, is definitely more effective because of the large size of the molecule and on the expenses of systemic VEGF depletion within 3 months. Doses have been less and less giving of bevacizumab. We give 0.625, and now even the 0.3 milligram dose is enough in those kids with ROP to prevent the progression of disease. Ranibizumab, because of the small molecule, is less effective in literature on the expense of less profound systemic effect. We have to be aware of the kid's eyes, and we go up to 6 months within 1.5 millimeter from the limbus. We simply inject under mask or even head stabilization with topical anesthesia, but we have to be really skilled, and we go directly with the needle inside the eye to prevent injury of the lens. As you can see, this injection would save sight for this child for the rest of his life once given on due time. And we really have to identify those kids that need treatment, because if we give this in poor conditions, there's always a risk of endophthalmitis, tractional detachment, regmatogenous detachment, cataract induction, insufficient treatment, need of repetition, a huge amount of risk that need to be dealt with in proper conditions. notice that we are all liable and responsible for the treatment. Here we go for such a child, male, single, 30 weeks, 1780 grams, delivered by C-section and presented with a very bad disease, a very bad looking disease, stage 3, zone 2 or posterior zone 2 with fibrovascular proliferation. This is zone 1 even and plus. So this was an indication for treatment. We advised for treatment and the father got panicked and he kind of left and he actually agreed on injection. You can see the 1 week post-injection, the immediate relief of the congestion and the reduction of the burden of the disease. You can compare here a very aggressive disease, a very angry fibrovascular ridge with a very now a less aggressive disease, and then the continuity, the beauty of the injection is that it allows the vessels to continue on a healthy retina without inducing field effects. This is a major review of situation analysis in Egypt. This is a paper I published in 2019, and it very much describes, it's available online at the Journal of Medical Research, and I think it has many important information for you to revise. So what if we have a bilateral stage 5 disease? Shall we intervene? Shall we do surgery? Many of us are skeptical about surgery and really they don't want to do surgery because the results are not good. But can we help? Yes, we can help. In a fraction of kids, in 20% of kids, in 30% of kids at most. Because this is how the retina looks like after desperate conditions. In those fraction of kids that we can assist. Our role is to remove the fibrous tissue and relieve the retina from traction, and hoping that the RPE pump will get the retina back in position. Of course, visual rehabilitation here is extremely important. Here are such examples where the retina is totally folded upon itself, and the retina now we can define and identify the macula here and here with important ambulatory vision. Another case, the retina is getting unfolded and the vision is getting fixation. Another case of stage 5 where the densirone here, and show you how we use it, helped a lot in in restoring vision. We go very anterior, and we have to be very careful about where the retina goes to the periphery. We do a lensectomy because we cannot access the membrane in stage 5 ROP. And then we start by severing the membrane behind the lens. And we have to identify that there is a space between the retina and the membrane. If you go central, we go sharp dissection, and then we eat up the membrane. You can see here the retina snapped back because the dragging was relieved in the center. We go gradually using scissors, using sharp dissection, bimanually to relieve more and more of the retina in the periphery. And you can see here the membrane goes way through the ciliary processes. We apply deep anterior indentation to bring the ciliary body and not into the towards the pupil for the retina to be safely preserved and preventing the ciliary body from snapping from a ciliary body detachment. Then we go for the stalk. We open the stalk and remove the fibrous band going into the optic nerve, as you can see, relieving as much of the traction as we can. So here we could do that nicely, and we open the stalk. We can see the optic nerve deep there at the back, and the peripheral traction, the equatorial, the anteroposterior membrane and the equatorial component has been largely eliminated. You can see we have to really excise this membrane way to the ciliary body. Here we used densirone. Densirone is a very useful heavy silicone oil, allowing to keep the retina back in position, especially when we go for removing the lens. The lens, I think keeping the lens is an additional success factor in such complicated surgery. You can see here the retina is flat in the posterior pole. The patient had peripheral fibrosis, and we attacked this in the second stage. After removing the densirone, we relieved the peripheral traction. So we revised our cases. Success in stage 4 is around 80%. and success is much less in stage 5, goes to 30%, and it improved with the new and improved techniques of using densirone, of staining the membrane with trypan blue, and being very meticulous and very expert in handling the eyes. One can ask, is it worth it? Well, this is the success story of a child. This child is coming from Iraq. He was blind for maybe a year and a half, and we could help him out. This is on his follow-up visit, and the glasses are put. He's aphakic, and you can see that he's moving around looking for the sweets and the candies. All the kids are very much taken by the lights, and this is amazing when you look at it. This is another girl coming and looking for the sweets. This is another boy. Very unfortunate that these are only a fraction of success. We wish that the success was more than 20 to 30%, even with improved technique. But this, an ambulatory vision where the child can see around, can walk around, for us is extremely gratifying in an extreme difficult condition that we all hope that we will not go into this stage whenever we have a child with ROP. So the take-home message now is 1 month after surgery, all of you should be getting involved in examining the premature babies in the incubator if it's necessary, or in your clinic if it's necessary. You remember using the small speculum, the 28 diopter lens, and the indirect ophthalmoscope with indentation to the periphery. Register and mark and keep these children seeing, especially that the treatment now, when indicated, is not only sight saving, I think it's also life saving. Thank you very much.